Thank you, Arun. And I mean, I really appreciate you highlighting the universal truth, right? Our words should match our deeds. And, in the event that they don't, then we need to, we need to watch what's happening. And right now, the deeds are replete with racism and discrimination, as you said. And when that changes, then trust will come. So thank you. As we discuss community trust, I would be remiss if I didn't, address COVID-19 and the vaccine hesitancy that's within the African-American community. We've talked a bit about the root of African-American distrust of the US healthcare system. But as we embark upon the largest vaccination effort in history, my question is for Dr. Stevenson. How do we ensure that the African-American community is participating in the herd immunity process? We are dying at 3 times the rate of our white counterparts, and there's so much at stake here.
Yeah, I mean, I think part of it is a little bit of what Arun was saying about things we already know. So, governments can still say we're surprised that there's a disparity that's going on. Just to notice it is thought of as an intervention, even though we've known it for so long. And so part of that means, how do we teach our own families and our own children about this narrative of dehumanization that shows up in every aspect of our communities? And so we have to keep reminding and beating down doors around how backward that knowledge is about our communities, that somehow just awakened to this disparity, even though it's been centuries of disparities. I think the other thing that comes to mind around how are we going to teach even our young people to fight for themselves in these spaces, right? How are we going to teach them to take care of themselves when they are stressed out in these moments in ways? The politics of standing up, I think, for injustice in systems. I tell a story. My brother, some people know Brian Stevenson, opened at Equal Justice Initiative, opened a museum down in Montgomery, Alabama, on lynching and peace and justice. And one of the things that happened is the Montgomery, Alabama newspaper in that town, in order to participate, had to admit to its wrongdoing over the years, in the centuries, and its contribution in publishing lynching events as part of its system. And I think one of the reckonings that have to happen if we're going to not continue this selective amnesia about the disparity of Black and brown people is that people have to come to a reckoning. Systems have to admit how they have contributed to the problems that we're now trying to address. And that means telling it all so that we can at least know from the get-go how we come to this place and that it's not new.
Thank you, Dr. Stevenson. And yes, and that that reckoning would then lead to just as Arun was talking about, that that trust that we need to build. So thank you. My next question is for Michael. Michael, the World Health Organization defines social determinants of health, or SDH, as the conditions in which people are born, grow, live, work, and age. SDH factors include housing, healthy food, and income. And research has shown that these factors can drive as much as 80% of health outcomes. Yet across the country, there is little investment in public health infrastructure. What can we learn from Massachusetts, which has one of the best supported public health systems in the country?
Well, it's an interesting question. When we were in college, we were activists on a campus in Minneapolis, St. Paul, coming out of Boston. And we used to frame ourselves the best of the worst. That though we had more students of color than any other college, it was ridiculous the numbers we had. And I would frame Massachusetts the same way I would frame this conversation. We are better than many other places and many other states, but it is disgusting how little we invest in our public health infrastructure, how much work we've done around health equity and access, how much we've adopted and embraced the fact that there is a historical taint of race in our society that plays out in terms of the social determinants. Dr. Stevenson and others in the room have lifted this up as well. We didn't get here by accident. So connecting the dots for people about housing insecurity. I call this pandemic our national Katrina. When that storm hit that area. We should have known who was more likely to die, who didn't have transportation, who couldn't stock up on food, who didn't have family to go live with, who didn't have resources to survive on, and who would most likely die. That's the same scenario we have with this pandemic. We're seeing the same thing play out like it did in 1918 with the Spanish flu, a few decades out of slavery, and now in 2020 and 2021 with this pandemic. Massachusetts does not invest in its public health infrastructure the way it should. So we have a fragmented public health system. However, there is an increased investment here compared to the rest of the country. We are right now still pushing the state to do better, to go beyond being the best of the worst. We had health reform here before the rest of the country had health reform, but we still have uninsured. We have people who are insured, but still Black and brown folks walk in emergency rooms with stage 4 cancer because they don't have a primary care medical home. We still know that people are uninsured. And if you're uninsured, that's an access issue. That's a product of racism. So we have a combination of things that we have to figure out, whether it's housing patterns and neighborhoods we were denied access into, the GI Bill and the lack of access we had to opportunity. We are right now debating a stimulus bill that will reposition Americans. I argue all the time, Dr. Stevenson, we never repositioned Black America. It was promised in Reconstruction. It never took place in the early 20th century. It didn't happen after World War I, World War II. It didn't happen with all of our infrastructure investments. We're about to be here again with an infrastructure bill. Let's see how many Black and brown folks get changed in terms of their condition based on billions, if not trillions of dollars going across the country. So while we can lift up Massachusetts for some accomplishments, we have a lot more to do. We have to seize the moment around this racial consciousness and this awareness around pandemic and turn that into a campaign for equity and justice and opportunity. And we have to seize that opportunity and be loud about it and declare that Black lives truly matter. It's not just about a knee on your neck. It's also about the people that are dying of diabetes and heart disease and cancer at a higher rate, and they're Black and brown.
Thank you. Thank you, Michael. We have to seize the opportunity and create long-standing change. Thank you. My next question is for Arun. Arun, what recommendations for next steps can public health organizations take as they think more creatively about a path forward in addressing racism as a public health crisis?
So I think that it's, the question of healthcare is a very interesting one. And as a non-expert amongst this panel of experts in specifically the question of healthcare, I've had the opportunity to work with our healthcare company, IBX in Philadelphia. And what I know is that healthcare companies have tremendous data. They know all of the things that you're saying. They've quantified them. They have health economists. They have, statistical analysis on every piece of this. And so what I think, and what we're partnering actually with IBX to do is we're forming what we are calling the Ending Racism Partnership. And it is a broad scale partnership across many different pillars. And we call a pillar an area, but health equity is one of them. Wealth and equity is another one. Jobs, education, housing, arts and culture, criminal justice reform and accountability. And I think that joining in with the others as a group of people who are soundly disavowing racism as a baseline for moving forward, that we are eliminating and committed to rooting out systemic and institutional racism in our systems and engaging in peer exchange network with other organizations doing the same, and doing that as an overall learning, development, and transformational strategy across regions and across the country is a principal first step to be able to do that publicly, to own the past, to disavow the past, to create action plans for the future, to be accountable to one and all publicly in a way that makes sense. Because until you are, it's Black History Month, I might as well quote Malcolm X, right? Malcolm X said, taking your hand off the handle of the knife that you stabbed me in the back with is not healing. You have to pull the knife out and there actually has to be healing, right? So there has been a tremendous betrayal of the institutional values that are ensconced in our Constitution. And I think that people have to get institutions, and especially predominantly white-led institutions, to openly, actively, and doggedly produce results that are pursuing the end of racism in our lifetime. It should not be a, we'll get there in 100 years affair.
Thank you. Thank you, Arun. Ending racism in our lifetime. Thank you.
This should be the generation that does it.
Agreed. Agreed. I want to open the floor to Nefertiri and see if she has any comments that she'd like to add to that question.
Hi, sorry, my daughter's just having a moment right now. I just want to say that you know, just in listening to everyone and being in this city and working in a, you know, for the past 5 years in this space, this work is incredibly difficult, right? We're talking about, you know, dealing with conditions in a community that have been created by centuries of laws, but laws not too long ago, like laws during the civil rights era, you know, that determined who could own property, where you could buy property, who could vote, where you could go to school, and so forth, you know. And thinking about all of this, one of the questions that plague us and that we haven't really addressed is, you know, what's the real root causes of the conditions that are causing these outcomes? So, you know, we can address health disparities and we can address all these different things, but if we aren't tackling the real root causes that are driving these outcomes, then we're not really going to see the change that we want to see. So we really need to be figuring out, you know, if you think about the tax structure, right, and how the tax structure is driving poverty, then should we be focused on the tax structure? You know, so really thinking about the root causes that are causing these outcomes. And I just also want to say that, you know, talking about race, and this is just me in this position, it's not easy. You know, it's always the elephant in the room, talking about race, right? But the thing is, if you look at the data, right now in Philadelphia, Black children are in poverty at 3 times the rate of white children, and Hispanic Latino children are in poverty at 4 times the rate of white children, right? And so if you look at the data, you can't deny that there are huge disparities and that there are huge gaps in outcomes. So you have to look at race. You have to be intentional about race, because if you're not, what we do know, right, is that a one-size approach doesn't fit all. We do know that if you address things to solve things for everyone, that's not going to improve things for those who are worse off. In order to improve things for those that are worse off, you have to focus on those who are worse off. And we're talking about brown children and Black children who are in poverty in the city. And so you really need to be intentional and you really need to be focused around this. The last thing I'll say is that, you know, where we are right now is we're dealing with a structure in the system and operating in a structure in a system where disparities are being maintained and perpetuated, but it's not necessarily intentional. You know, we're not dealing with necessarily explicit overt racism. We're dealing with structures that where we're operating and conditions are being maintained by status quo, you know. And so it's not that we're in a system where people are being intentional. This is often unintentional, inadvertent, status quo decision making and processes that are continuing to keep people in poverty and locked into these systems and locked into these structures. And you can't get at a society where race doesn't predict success, you know. And so I'm saying that to say that, you know, Aaron mentioned earlier that we don't have a white person on the panel. That, you know, I'm mentioning that because it does take everyone, right? We do need shared accountability. We do need shared responsibility. It can't be on those who are being burdened by the system to come up with the strategies and the solutions to adjust and modify the system so that they can have more equitable outcomes. It has to be shared responsibility. It has to be shared accountability in order to change these structures and get at different outcomes.
Wow, thank you, Nefertiri. I mean, you've said a lot, and so before I turn it over to Marlon for Q&A, I just want to open the panel up and ask any panelist: are there any closing remarks, any comments to some of the things that Nefertiri mentioned, the root causes, to the health inequities, just anything? Is there something that anyone would like to share?
Rita, if I could offer this one closing comment. Researchers here in Boston came into a group of us a few years ago and asked us and introduced us to this term called the weathering effect. And they said that they went in and asked Black parents to rate their kids' asthma from 1 to 10. And parents like my mother, I had asthma, rated them 3 or 4. And then they asked the doctors to evaluate those same kids, and they were 8, 9s, and 10s. And the purpose of that introduction to this term weathering effect is that those parents got so used to taking the pump every day, the Flovent, the Alupin, popping the pill, being in the ER once a month or every quarter, that they were weathered to being sick. So I asked the question, what are we weathered to? Are you weathered to getting stopped by the police? Are you weathered to these police-involved deaths? Are you weathered to the crime and death in our communities from the hands of young people? Are you weathered to being asked for your ID with your credit card when you walk into a store or being followed through a store? I would say to everyone's comments today, we've been weathered to a lot, and we've internalized a lot, and we need to start unwrapping what that weathering looks like for all of us. And I'm inspired by this conversation today as we talk about how we've been impacted by the institution of racism.
Thank you, Michael.
I would just throw in, I appreciate just what Michael was saying, that sometimes we sacrifice healing for the sake of survival, and our models have to think about thriving more than resilience. Resilience is not enough. It's just a stop on the journey. And part of the work of, even in our communities, we have resources, we have healing. The talk in our research, children who say their parents talk to them about these issues do better around academic achievement, around anger management, anxiety management. And so we have cultural strategies that we need to highlight and upscale with resources. And barbers are amazing therapists, beauty salons, we have plenty of resources, but how do we build and invest in them so that they are magical? And I'm also just want to say how powerful it is that Nefertiri's daughter was listening to all of her powerful words, and you see the result. I just think that's an example of what I'm talking about. So,
thank you, Dr. Stevenson. Okay, well, I mean, this was a great way to wrap up our panel discussion. And before I turn it over to Marlon, I just want to thank the panelists for sharing their thoughts and allowing me to lead this portion of the discussion. And I also want to thank PHMC for the opportunity to host this panel, and for bringing important topics like racism as a public health crisis to the forefront. So thank you again. And with that, I'm going to turn it over to Marlon for Q&A.
Great. Thank you so much. Thank you so much, Rita, and thank you so much to our panelists. We do have a question that I'd like to pose and ask for maybe one or two panelists to respond to. One of our participants states that a few years ago they were in Cuba, and the health system produces better outcomes for Black and brown people. Lower infant mortality, higher life expectancy. How is this so with our world-class medical institutions here in the United States? Why such a disparity? And we invite any one or two of our panelists to respond.
So I mean, I can't quite speak to Cuba and why they're doing so well, but I think we can talk a little bit about why we're doing so poorly. I mean, we all know the literature about the rates for Black women with morbidity and mortality around childbirth, right? Infant mortality for Black babies. And it's concerning data. And this is, again, data that the OBs have recognized And when we look at why that is, it's everything that the panel has been speaking about today in terms of systemic and institutional racism. So part of it is bias, right? And part of it's implicit bias. And of course, there's always going to be explicit biases as well that lead to Black women, in particular, Latinx women as well, receiving different quality of care, right? So when we talk about health disparities and we're looking about health equity, we have to think about access, we have to think about quality, we have to think about the relationship between the physician and the patient. So we know that these are some of the reasons why Black women in the United States and Black babies have higher rates of infant mortality than many other countries where there are folks from the diaspora. We also know that we can do better, and I can speak towards for Penn, and I think probably most hospitals across the country, now that they've really looked at that data, and that data has been continuing for years. But Serena Williams put a spotlight on it. The NIH lost a African-American woman researcher after childbirth, whose work was in this exact area. And so I think that with all of those lights, much like the ones that we've had in the past year for the murder of George Floyd, people are trying to do better. They're trying to gather data on why Black women are treated differently, what that looks like. Is it about access? Is it about lack of transportation? Is it about not having clinics in their neighborhoods that they can get to? All of those factors are being examined. That's why the data is so important. But where Arun said, gathering data is fine, but it doesn't mean anything if you don't act on it. So there are those two pieces of trying to understand why this is occurring and then ensuring that it doesn't occur any longer.
And Marlon, just as somebody who's been to Cuba twice and actually looked at the healthcare system in both of my visits, I think it may be a flawed comparison. We know that some of the best doctors in the world come out of Cuba, and they put resources and attention into the training of doctors from Cuba. In fact, Cuban doctors travel the world to get training and to bring their expertise, and then to bring that back to Cuba. So there's investment in there, but they're also a poor country. So if you've ever been to Cuba, you would see those same households that may have a longer lifespan and maybe not the same health conditions, that also go to home impoverished households that don't have access to resources. So I think the challenge for us as a country is we need to understand that a historical minute ago, our doctors on this call couldn't have even practiced in the same hospitals as white doctors. We're talking about Medicare, Medicaid in the 1960s. That's a historical minute ago. If you're talking about the Institute of Medicine's unequal treatment report, validated what those Black activists were saying when I was in the projects in Roxbury, just a stone's throw from where New Edition grew up. And they were saying, Black doctors don't treat us the same. I mean, doctors don't treat us the same. They won't give us the privileges when we're Black doctors. They won't give us research dollars for clinical trials. All of that's come true now. We now realize that all of that was true, and now it's being validated by established medical organizations or the Institute of Medicine. So we have to come to the realization, as Arun said, this is not new. Folks have been saying this for a long time. It's just America's waking up. My last point on that is it's not all about implicit bias and ignorance. I tell people all the time, 74 million people voted the wrong way, and they voted for hate. And they're doctors, they're lawyers, they're judges, they're epidemiologists, they're scientists, they're teachers, they're guidance counselors. And that hate is showing up somewhere. And I would argue it's also showing up in our medical profession as well.
Great. Thank you. Thank you for those responses. Just one more question before we turn it over for closing. And I ask just if one of our panelists wouldn't mind speaking to this one. You talked earlier about social determinants of health and underlying root causes as something that needs to be addressed in order to combat inequality. I wonder if one of our panelists could consider the negative impacts of capitalism as a driver of racial and ethnic inequalities, and if there are any, if an alternative such as democratic socialism would be favorable.
Take that one. So I mean, the second part of the question I think is what do you say? It's like philosophical, right? The first part of the question is we live in capitalism. Capitalism defined people who were brought to this country as capital, right? So there is a social contract that said people have certain rights, but these folks aren't people. We need a new way that a social construct is constructed that summarily ends this idea that economic and social oppression should be the basis under which we all operate, right? And the reason why I say that, and again, you know, I do note that we are all people of color on this screen. You know, when a woman experiences domestic violence, you can do a lot to try to repair the damage. You can, you know, resilience and counseling or whatnot. But really the violence is on the other party, right? The ownership of the act of violence should be with the party that did the act of violence. And all of the emphasis should not be on the people or the person who is the victim of violence, right? So I think in this idea of, you know, we live in a capitalist society and a lot of people really benefited. Like the Queen of England didn't just become rich on anything but the transatlantic slave trade, correct? So, I mean, there is a function within society that says, hey, if you have reaped this horrible thing on society, how are you going to fix it? How are you going to come to the table with significant, major investments and not 7 digits or 8 digits, but I'm talking really 9-digit and 10-digit investments in communities so that they can be made whole, not just left behind, because the reality is the wealth is there in our country. The wealth is there in our region. The wealth is there probably in many of your institutions to make a significant contribution to repair the damage. So I think that all of us need to look at those questions directly and start to challenge institutional and systemic leadership to see how you're going to make significant, bold investments to take our country and turn it into the right direction for everybody.
Thank you, Arun. Thank you for that. Thank you for that response. We're approaching the end of our program for today. For those questions that we were not able to get to, we can certainly tap our panel afterwards and get some responses to those questions and post those answers on our intranet. So I'm going to turn this portion of the program over to Celeste for some closing remarks.
I think the closing remarks have already been said, and most of these discussions I kind of end with, there's nothing else to say other than we haven't come to the end, only the end of this discussion, as one of our esteemed guests said here today, that you know, we're inspired by this discussion because maybe even a year or 2 ago or 7 months ago, these discussions were not happening. We were not able to be as transparent as we feel is comfortable today to do what we're having these discussions and having our own admittance around some biases, whether they're conscious or unconscious. I will just say this, someone said earlier, this was a moment or a movement, and those can be, but where we are at PHMC, and I hear that in all of you, and thank you richly for being here in your authentic selves, is that we really need to take the moment to the movement, to the actions. And that really starts with the acknowledgement of so many, and also acknowledge that we are really in this all together. So there's no end to this. I think we would love to bring you all back when it next week or the week after we shall meet again. I want to thank you all for giving us your precious time and authentic views. And we shall see you again, and thank you all. All right. I want to also, on behalf of our Governance Council, DI Governance Council, thank you for all your support. Thank everyone. Thank our staff members for being here. Continue to look this month. We celebrate the accomplishments and the trials and tribulations of African Americans, and we ask you to do the same thing. Please look for our postings. Join us next week as we close out this official month, but not closing out overall. And just a plug for your African American, culturally, your recipes that bring something that you want to share for our upcoming cultural recipe book that'll be posted online. So we ask you to do that. Thank you all to our esteemed guests today, and everybody have a good one. Be safe out there. All right. Bye, everyone. Thank you, Rita. And thank you, Rita, for bringing a great group facilitating today. Thank you.
Thank you, everyone.
Yes.
Thank
Take
you.
care. Bye.